Good morning, good afternoon, good evening, friends, depending upon which parts of the world you are joining us from. This is Dr. Vijay Agarwal. I'm the president of Consortium of Accredited Healthcare Organizations, welcoming you all to another exciting session in the international webinar series, which is hosted by CAHO and ISQua together. It is indeed really one of the, I would say, a important event that has become that people wait for the first Tuesday of every month. We all know that CAHO is a not-for-profit body and is looking at promoting patient safety, quality, and accreditation, not only in the country. Now we want to shake hands with all the other adjoining nations who have the same aim and goal. CAHO has three vertical divisions, one which is to look after the healthcare institutions, the diagnostic centers, as well as the quality professionals. So without much ado, now the moderator for today is Dr. Clive Fernandes. He is one of the most charismatic, I would say, quality person of India. He is the group clinical director of Wokhart Group of Hospitals, and as a head of that institution, he ensures that clinical excellence, nursing quality, and accreditation standards are met across all Wokhart hospitals. He works closely with the group's department heads as well as the key members from the medical fraternity to promote quality healthcare solutions and sort out operational issues in his unit. He has implemented many quality and operational initiatives that have led to optimum utilization of current resources and improved delivery of healthcare services across the group of hospitals. With a career span that spans over more than 19 years, Dr. Fernandes is a veteran when it comes to hospital administration. And his key areas of interest are quality, medication management, which is the topic for the day, hospital operations, service excellence, and administration. And to introduce the charismatic speaker, Dr. David Bates, I hand over to Dr. Clive Fernandes to introduce the topic and the speaker for the day. Thank you.
Thank you, Dr. Vijay, and thank you, CAHO, for giving me this opportunity. And apart from saying good morning and good evening to people wherever they are, I see a lot of our participants are from Indonesia. I've done a lot of JCI work there. So Salamat Pagi to everybody in Indonesia. Salamat Pagi. Hope you're doing well. You know, when we talk about medication errors, I just want to share an incident. We were just 6 people who had logged in. And even in the 6 people, you know, my email login got mixed up with somebody else and I could not connect. And I was just thinking, did this happen by chance? Or is it a wonderful opportunity to understand that with 6 people, if the wrong person logs on to the wrong connection with medications where you have numerable doses, you know, what can happen? You know, so, and they say primum non nocere, first do no harm. Nobody needs an introduction to the IOM report of 1997. I won't even go there. I just have a minute to talk about, you know, healthcare in India. So Dr. Vijay, Dr. David, you know, an interesting story that in 2005, when I first joined the corporate sector and I asked someone, you know, we were told I'm supposed to track medication errors, and I asked them, what is your medication error rate? And they said 0. Wow. And they said 0, and I was amazed because I had no clue what this is, but they said 0. And then over a period of time, I realized they said 0 because they did not know what to do. They did not know what to quantify. Today, if you ask somebody again, what is your medication error rate? A lot of water has flown below the bridge, but still people say 0. The goalpost has changed, but today it is 0 because JCI, NABH, if you show them errors, you're in trouble. If you show them errors, they're going to talk about root cause analysis, then you're going to be in bigger trouble. If you talk about root cause analysis, then they'll talk about incident reporting. You know, so I think in India, in the last 15-20 years, a lot has been done, but the goalpost has changed so much that the focus today is not medication errors. It is how to show 0 medication errors to anyone who comes so that I am perceived. The important word is perceived. I'm perceived as a good organization. today I think all our viewers, in our midst, it's an honor for me to introduce to you Dr. David Bates, who needs no introduction, but still, because that is one part of the job that Lalu has given me. So I have to do it well so that she calls me again. So I have the pleasure of, introducing to you Dr. David Bates, who is our speaker for today. He's an internationally renowned expert in patient safety, and this is going to, interest a lot of you. He has the expertise in, how you use information technology for, to improve care. And one thing which is very striking is, cost effectiveness and outcomes. So Dr. David is an expert in that. He is a professor of medicine at Harvard Medical School and a professor of health policy and management at Harvard School of Public Health. He directs the Center for Patient Safety Research and practice at Brigham and Women's Hospital. He is the immediate past president of the ISQua and the editor of the Journal of Patient Safety. It's a big thing, introducing. I don't know why they said 6 o'clock we end. If I start introducing Dr. David with all his credentials, we'll be here for some time. But I need to tell this, I need to, it's an honor, sir. He serves as the principal investigator of the Health Information Technology CERT. He has been elected to the Institute of Medicine, the American Society for Clinical Investigations, the Association of American Physicians, the American College of Medical Informatics. What is important and what is very interesting to learn, he has published over 700 peer-reviewed papers and has an H index of 115. Which ranks him among the 400 most cited biomedical researchers of any time. And today, Dr. David is here to share. Dr. David is going to share with us his experience and some things on medication safety. For all our viewers, there is one thing, if I have to sum up Dr. David in 3 lines before I hand over to him. Dr. David is one of the world's leading experts in the epidemiology of medication safety and on using technology to improve, it. So today we all know one size does not fit all, and today it's an opportunity to interact with Dr. David, hear from him, and see what we can take back. So welcome, Dr. David. It's an honor and a pleasure for all our viewers.
Thank you, Dr. Fernandes. Thank you, CAHO, for giving me this opportunity. It's a pleasure to speak to all of you and to do so on behalf of ISQua. Thank you also, Dr. Agarwal, Dr. Lalu, Dr. Jagasati, Dr. Patil, Dr. Chumani. There are many things about this pandemic that I'm really tired of. One is that it's so hard to travel. But one of the good things is the opportunity to share some things in ways like this webinar. And it's amazing to me that there are so many people on this event, not just from India, but also from Indonesia and Malaysia and even Japan. And one person signed on from Panama. So this gives us a way for friends and colleagues to get together in ways that were not really possible for us to do, say, even 10 years ago. And I'm going to talk today about improving medication safety in the modern era. I'll start with talking a bit about what we know about improving medication safety. I'll talk about computer order entry, barcoding, medication reconciliation, and the electronic records, smart pump. There are many possibilities for harm and pitfalls. I'll talk a bit about that. Then I'll talk about the current state where we are, and I'll wrap up. And I recognize that this is not what's going on in India today, but this is a direction that you'll want to move in. So what about the importance of medication safety? Well, drugs are one of the biggest causes of harm, similar to hospital infections. And just as Dr. Fernandes said, many institutions in this country, roughly a third, said that they had no medication errors. If you say you have no medication errors, it usually means that you're not looking. In inpatients, opiates are one big cause. They're usually about 20% of adverse drug events. There's also a lot of harm related to medications in the outpatient setting. And in the US, there's a lot of focus today on the opiate crisis. Both legal and illegal drugs play a role. So this slide just shows the relationships between medication errors, potential adverse drug events, and adverse drug events. Medication errors are common, but most of them have little or no potential for harm. A small proportion, the potential adverse drug events, do have the potential to harm a patient, but most of those do not harm patients. The ones that we're really the most concerned about is the preventable adverse drug events, which are the errors that do actually harm someone. And even most things that do harm someone are not preventable. We did a study in which we looked at this empirically. It's still, as far as I know, the only study that looked at medication errors, potential adverse drug events, and then adverse drug events all in one study. And we looked at 10,070 orders. We found 530 medication errors, 35 potential adverse drug events or things that could have harmed someone, and then 5 that actually did. And overall, that suggests that about 1 in 100 medication errors results in an adverse drug event, and 7 in 100 have the potential to do so. We then went on a long time ago now and did the study that I'm perhaps best known for, which is called the Adverse Drug Event Prevention Study. And the key findings of that study were that there were 6.5 adverse drug events for every 100 admissions. 28%, or about a third, were preventable. There were 3 potential adverse drug events for every preventable adverse drug event, and 62% of the errors were at the ordering and transcription stages. And that was a bit of a surprise because many of the studies to that point had assumed that ordering was done by physicians and then it was always done correctly. And what this showed was that really was not the case. We also looked at the costs of these events and showed that they're expensive. They cost nearly $2,500 at that time per adverse drug event, and even more for preventable events. Another study was done in another state in Utah, and they reached an estimate that was about the same as ours. And we estimated that just at our hospital, the costs for all adverse drug events were $5.6 million a year, and roughly half of that was preventable. And that didn't include any of the costs of injuries to patients. It didn't include malpractice costs or the costs of admissions due to adverse drug events. This is the kind of thing that we've been able to use to justify prevention efforts to our leadership. Later, we did an intervention study to try and reduce some of this harm. And we looked at in phase 1 at all patients admitted to a stratified random sample of medical and surgical units over a 6-month period. And then in phase 2, we looked at all patients admitted to the same units and then picked 2 randomly selected additional units. The interventions that we studied were computerized physician order entry for all units, and then a team-based intervention that included changing the role of pharmacists for half the unit. Now, computer order entry improves the safety of medication ordering in a variety of ways. So it streamlines and structures the process. You can decrease the transcription. You can require complete orders. I was really struck by how many orders did not include a dose or a route or a frequency, and occasionally even the name of the drug. You can give information at the time that you need to do so you can show relevant laboratories, display guidelines, and put in place guided dose algorithms. And then you can do all these checks in the background for things like drug allergies, drug-drug interactions, and so on. So we did this trial, and computer order entry at that time was pretty simple. It required that all orders be complete. It minimized transcription. And we had some early checking, including drug allergy and drug-drug interaction checking. And still, despite the fact that it was pretty early, we saw a 55% decrease in the serious medication error rate and a 17% decrease in the preventable adverse drug event rate. There was no change with the team intervention. So if you look at this by stage, again, 49% of the errors were at the ordering stage in the beginning. 14% were at the dispensing stage. The administration stage included 26%, and then transcription errors were 11%. So if you think about the process, there are a number of things that you can do to improve its safety. The first and most important is computerized physician order entry, but there are other things that are really important too. Barcoding, smart pumps, computerized monitoring for adverse drug events, and having a pharmacist contact patients after they go home, because patients often suffer problems after they go home. A couple of reviews have looked at computer order entry and medication safety, and they've confirmed that it's a powerful tool for improving safety. One study suggested a 66% reduction in prescribing errors on average. And another study that looked at both computer order entry and adverse drug events, 5 of 10 studies, 5 showed a decrease in the adverse drug event rate, 4 showed non-significant trends, 1 showed no effect. That's about what you'd expect, because most of these were not powered to detect a difference in the frequency of adverse drug events. The rules that we use are often not as good as they should be. And this is work that was led by Dr. Nidhi Shah, was published in the Journal of the American Medical Informatics Association in 2006. In most of the systems, even when you display alert, most of those alerts get overridden. And what we did was to go through and turn off a lot of the unimportant ones. And we found that over a 6-month period, we had 18,000 alerts roughly. 71% were non-interruptive. So that means they appeared in some part of the screen, but the physician didn't need to do anything. 29% were interruptive. And of the interruptive alerts, 67% were accepted. So that's the kind of performance you can see. As you'll hear later, we're not at that level of performance now. We're often just displaying alerts to physicians like crazy, and they're overriding nearly all of them. And that's not very helpful for improving medication safety. We also showed early on that tiering was really important for improving improving the rate at which people respond to events. So here we studied 2 academic centers. They used the same knowledge base. Site A used 3 tiers. The top tier was stop, you can't proceed. The next tier was we think you should do something different. And then tier 3 was, we're going to make you aware of it, but you don't have to do anything differently. Site B had all the alerts as interruptive or level 2. And what we found was that at site A, 100% of the time people stopped when they got one of the most severe warnings, versus only 34% at the non-tiered site. So that means 66% of the time people were running the stop sign. And the overall alert acceptance rate was also higher at the tiered site, 29% versus 10%. We also went through and then figured out which drug interactions are the most important. This is work that was led by Dr. Shilpa Fansalkar. And here what we found was that there were just 15 drug class pairs that were really, really important. And basically, you should never give those drugs together. They're candidates for hard stop alerts. I think they probably should be hard stop alerts. We weren't sure that this is the absolute complete set of these, but these were the pairs that our experts agreed about. I do want to underscore that the less significant drug-drug interactions are still important. They're much more prevalent. They probably cause much more harm. That's things like warfarin and sulfadrug, which is the sort of thing that is given all the time. They tend to depend on patient characteristics like drug doses and timing, and concomitant conditions like hyperkalemia. And to improve the sensitivity and specificity of these, we need more investment in evidence review and generation, and then methods for making drug-drug interaction alerts conditional on patient data. One of the things that we've done that we're really excited about in the US is to develop a tool, which is essentially a plate simulator for computer order entry, in which hospitals take orders and put them into a computer system with test patients. And you can then check and see how well your own system is working. And when we started this, we got 62 hospitals around the country to voluntarily participate. And we found that simulation detected only 53% of the orders, which had actually killed someone. So really not very good performance. And it detected only between 10 and 82% of orders, which would have caused serious adverse drug events. Notably, there was almost no relationship with vendor. People had the feeling that if you bought the right vendor, your system would be safe. This shows that was really not the case. And here are some data about that from the paper we published in Health Affairs. And you can see that there was a huge range of performance within vendors. And the point is, each individual hospital has a lot of ability to tune their system and to turn the warnings on or to turn them off. And the performance that you got depended on where you had set that. Notably, most of the institutions had no insight as to where they were on this spectrum. And over time, we've done more with this. We also, another study that we did showed that the better you do on this particular test, the better your safety is. So there was a 43% reduction in your medication error rate for every 5% increase in the leapfrog score. And there were also 4 fewer preventable adverse drug events for every 100 admissions for 5% increase in your score. So if you do better on this, you deliver safer care. And over time, the number of hospitals taking the test has gone up a lot. We have about 5,000 hospitals in the US, and we now have close to 2,000 taking the test on an annual basis. And the average percent correct has gone up a bit, but we keep making the test a little bit harder. And hospitals continue to learn, even if they've taken the test every year. And I think this kind of post-implementation testing is a really useful thing going forward. This is something that as computer entry becomes more frequent in India, you might consider. Another technology which is potentially really helpful for improving medication safety is smart pumps. These are pumps that can be told what drug is being given, so that there can be a checking put in place to make sure that the dosage that the patient's getting is correct. And we did a study of this early on and showed that serious IV med errors were frequent, and we could detect them using smart pumps. However, we found no impact on the serious medication error rate or the preventable adverse drug event rate. And that was almost certainly because of poor compliance on the part of nurses, suggesting that both behavioral and technological factors have to be addressed if smart pumps to achieve their potential for improving medication safety. We did this work directly with a vendor, and they then went through and changed their application to make it much safer. Another type of error which can be tragic is putting the wrong medication into a medication cart. And we had a case in Indiana in which 3 babies died as the result of having adult strength heparin put into the carts that were going to neonatal care units. And this is something that if it's actually administered, it's usually fatal. The first baby died. They weren't able to figure out what was going on. The second baby died. Still, there was confusion, and not until the third baby died in this unit in Indiana did they figure out what was actually going on. Now, barcoding we use in supermarkets, for example, all the time. We should be using it in healthcare too. And this slide just shows a study that we did that was led by Dr. Poon that looks at the dispensing error rate after you put in place barcoding. And the dispensing error rate fell substantially, 31%. The potential adverse drug event rate fell even more, 63%. And we did a formal cost benefit analysis of this, showed that the 5-year cumulative costs were 2.3 million, but the 5-year cumulative benefits were 5.5 million. So, and the break even was within the first year after go live. So not only does this improve safety, but it's cost effective. We also then looked at the impact of putting barcoding in place at the bedside. And this is the place where it probably has the biggest impact. Now, this is a study that was published in the New England Journal, again, led by Dr. Eric Kuhn, and we showed that the medication error rate fell by 41% after you put in place barcoding, and the potential adverse drug event rate fell by 51%. And this has resulted in barcoding being nearly universally adopted now in the US. It's been made a safe practice, and it's expected that you have barcoding of medications in place at your institution. Another thing which is pretty simple, but can also make a big difference, is intervening post-discharge. And this is work that was led by Dr. Jeff Schnipper. Here we did having a trial of having a pharmacist call patients 3 to 5 days after they're admitted. And what we showed was the preventable adverse drug event rate incidence was just 1% in the intervention group versus 11% in the control group. Now, a problem in getting this implemented in the US is that our insurance doesn't pay for it in most states. But this is something that clearly improves safety. So if you look at the inpatient puzzle overall, there are many different pieces. I think computerizing ordering is the most important one, but barcoding is important too. So is point of care technology, so are smart pumps, so is doing better with medication reconciliation. In the US still today, many of these don't communicate with each other. They should. And we also need monitoring for medication errors and adverse drug events and spontaneous reporting. I want to take you through a couple of things that really concern people in the US in this area. One was a study that was done in the University of Pittsburgh in pediatrics, looking at computer order entry. They studied children who are being transported in for special care. And the authors in this study that was published in Pediatrics showed that the mortality rate went up from 2.8% to 6.3%, so an odds ratio of 3.3, after a commercial computer order entry application was introduced. Now, the study design was before or after. There were other changes that were made at the same time that computer order entry was implemented, and they didn't report the overall mortality rate, which is a little surprising. But when you dig deeper into this and you put on your quality and safety hat, you find a number of important things. First of all, they'd introduced computer order entry very rapidly over 6 days, which is probably too fast for that big a change. After implementation, order entry wasn't allowed until the patient had actually entered the hospital and had been logged into the system. And the kids that they were studying were kids who came in often in a helicopter or certainly in an ambulance. And in the past, many of the orders had been written while the patient was still on the way, so that by the time that the child got to the institution, everything could be ready for them. After computer order entry implementation in this study, all the drugs, including the vasoactive drugs, were moved to the central pharmacy, which was very far away from intensive care. A rule was put in place that the pharmacy couldn't process medication orders until after they were activated. Many of the order sets or groups of orders weren't available initially, and that turns out to be a huge deal because it's faster to write order sets on the computer, but it's a lot slower to write individual orders. And the net result here was substantial delays in care delivery, and it's possible that this introduction did in fact cause these problems. Now, this study was quite weak methodologically. It was before or after, but the increase in the mortality rate was large and of obvious concern. And introducing these big delays in the group could have caused these problems. But if you dig deeper, many of the rules for implementation were not followed. And it's just essential for other organizations to handle these socio-technical aspects better. There have been other studies that looked at the same question. Another study at the University of Washington in their pediatric intensive care unit looked at before and after implementation of order entry, and it was actually exactly the same commercial order entry system. And they showed that their mortality rate actually fell. And another study that was done in another institution, Montefiore, showed the same thing, that their rates fell. So almost certainly this was related to how things were implemented in Pittsburgh. And I think that's a powerful message in terms of quality and safety. So if you look at the process overall, with the ordering errors, order entry reduces the ordering error rate 55%. Barcoding in the pharmacy, it reduces the dispensing error rate by 67%. For administration errors, you see a 51% reduction. And for transcription errors, there's a 100% reduction. So there are big reductions at every stage of the process. And the reductions that you could see could be even larger than this if you really do things well. So, so what has changed over this period? Well, we now in the US have nearly universal use of electronic health records in the inpatient and the outpatient setting. That's increasingly true in other developed countries. In most parts of Europe, for example, there's universal use in the outpatient setting, but not necessarily in the inpatient setting. There's computerized prescribing. In the US, prescriptions go electronically directly to pharmacies, which is a big win. But there's still problems. In particular, clinical decision support is not yet delivering around medication safety, and I'll tell you some more about that in a bit. And prescriptions often still are not received in coded form, which is a problem. Here's a study that was led by Dr. Adrian Wong that was published in 2018. And we looked at decision support overrides in the intensive care unit. We looked at 6 ICUs, identified 2,448 overridden alerts. The doctors were appropriate to override 81% of the time. There were more adverse drug events found after inappropriate overrides, as you'd expect. So 16.5 versus 2.7. And the implication there is we have to do better with our decision support in terms of positive predictive value. Here's an even more troubling study that we did recently. This study was led by Dr. Adam Wright. We looked at drug-drug interactions after conversion to a commercial electronic record. The overall alert burden, the rate at which people saw alerts increased by a factor of 6. The acceptance rate for the most severe warnings fell from 100%, as you weren't allowed to override before, to 8.4%. So people, even for the things that you should basically never give a patient, were overriding 92% of the time. And the override rate fell from 29.3% to 7.5% for medium warnings. The institution did then disable the least severe alerts, and that dropped the warning rate by about half, but the acceptance rate for the most severe only increased from 9.1 to 12.7%. So that's still very poor performance. And the implication is we have to refine the underlying decision support and turn off more of the false positives. For opiates in particular, we still have big problems with opiates here. You can profile both patients and doctors and see what they're doing in their prescription monitoring programs in nearly every state now. It should be easy, makes it easy for prescribers to identify problem situations. You can track individual patients over time, identify those with potential for dependency, and then point patients and providers to appropriate programs. There are a number of things that are going on the technical front. So there are new sensors which can detect what medication is in a solution and at what concentration. Pumps can be wirelessly updated so that you don't have to do a lot of programming with them. There can be seamless linkages between centralized teach systems, and delivery devices. Monitoring can be used in many locations, including the home. We've done some studies of contactless monitoring, in which you have a device that goes between the mattress and the bed so it never touches the patient. And it can monitor things like respiratory rate and pulse very accurately. And big data techniques and artificial intelligence are likely to be increasingly important. So, what will it take to transform care? Well, from the medication safety front, I think in the inpatient side, the key issue is making our essential processes more reliable. You do need to put in place approaches like computer order entry and barcoding. They should be linked. You should use clinical pharmacists to their best advantage. They are really important for improving medication safety. And it's also critical how you measure performance. In the outpatient front, computerizing prescribing is important, so is putting in place strong decision support, addressing issues of adherence, because patients often don't take what we prescribe, using clinical pharmacists to best advantage, monitoring patients better, and then in all settings, leveraging data to personalize suggestions for patients. So to wrap up, many interventions that don't involve health IT can improve medication safety, especially having pharmacists in clinical roles. That is so important. However, I think health information technology is going to have the biggest impact, especially in the inpatient setting. And computer order entry and barcoding and smart pumps are the highest leverage. But if you want to get benefits from any health information technology solution, you have to address cultural and implementation issues. We're still learning about what to do about outpatients. As I described, any technology can and will create new problems, and you have to go through, track those, and systematically engineer them out. And here is a guess of what some of the future might look like for India. I would say that an early step will be to computerize prescribing both inside and outside the hospital. Then work towards barcoding of medications throughout, take advantage of the skills of pharmacists, and then finally enable prescriptions to be sent electronically. Einstein has said that insanity is doing the same things the same way and expecting different results. And we need to change the way that we're doing things in medication safety. So I'll stop there and take some questions.
Wow, thank you, Dr. David. That was an interesting presentation. We have 5 questions and we have some time, and I just wanted to sum up for our audience, some of what Dr. David said, I was writing, and some of the questions are also related to that. When we talk about medication errors, we say nil medication errors. I like one of the stats that Dr. David put up. Okay, we don't have any medication errors. We're a lovely organization, but we have admissions, right? Let's look at our stats, because one of the stats said that for every 100 admissions, you have 6.5 adverse drug events. So you may not have medication errors. Go back and look at this. Dr. David, one thing I wanted to, just share with you. We talked about CPOE, we talked about barcoding. I think that's the way going forward. But what I like, what you just said, technology also can create problems, and you're only as good as your technology. See, till the mindset does not change, you have, till the human mindset does not change, technology can play a limited role. And why I'm saying this, I love the part you put on the alerts. The system is made to give you alerts, but then as humans, we intervene and we press one button called override. And it is not only for this. CPOE, you're only as good as your tool. A CPOE in India, I'm talking primarily about India, CPOE is supposed to be a computerized physician order entry form. Now, it actually means that my physician, who is a demigod status here, he has to log in and he has to, punch it in. But if he does something of that sort, it's below his status. So invariably what happens? Invariably his password is given to the resident. His password is given to a resident. So you'll have in the Department of Surgery someone writing tablet beta log 600 mg, and when you tell him what is this, He says, I don't know, it is not my I had the password, I did it, So you're only as good as what technology tells you, but that was a lovely point. Third thing which I liked, which I picked up from your presentation, and I'd like to share with everyone. Sometimes we always think costs are prohibitive. But when I saw the barcoding thing, and you know what, the moment you said it, it switched me on, because you said we use it in supermarkets, and I realized, yes, we use it for tissues, we use it for everything. But when it comes to healthcare, and you talk to leaders about barcoding, they say, oh my God, that is expensive. And then the study shows that, you can break even in 1 year, and I'm not even looking at that. I said that break even in 1 year should be kept as your bonus. You did not have medication errors and patient safety was not compromised is something that you should look at. Everything else comes at a bonus. So I think for a very good presentation, the CPOE, barcoding, a lot that we can do. In India especially, there is one thing, and sir, I would like to take a screenshot of what you said, recognize pharmacist. Well, unfortunately, a pharmacist, and I'm saying this based on experience. I have been with JCI 14 years. I have gone to 40 countries. I've audited over 140 organizations. A pharmacist in India is still not looked at a pharmacist the way they are looked out in the West. Till we don't get that recognition, if they are just looked at someone who you can press the override button, or you can press, the delete, control, alt and delete, the technology will not work. So there's a lovely question. So, I'll begin with someone asked, and this is a problem. It's not in the serial number 1, but this is a problem that happens everywhere. This is Sheikh is asking a question. Most of the medical errors are underreported. So what can we do to improve reporting?
Well, there are a number of things. I mean, the key thing is to make it clear to everybody in the organization that you will not get blamed if you report an error. That's what people worry about. And many times when something bad happens, the leadership response is to go in and fire the person who made the mistake and fire the other people who might have been involved. That really makes everybody not want to report things. So the key thing there is establishing a good safety climate. One thing I didn't talk about today, though, is how to find the things that actually hurt people related to drugs. And that, I think, is best done by using the computer system. We built approaches now, and a number of companies have, that go through and look at what's in the information system and then find things that suggest that a patient had a harm related to a drug. And that will give us a true sense of how many people are being harmed by medications. We still need reporting for the errors and for the near misses. You can't find those so easily by using the kind of approach that I'm describing.
So I think an excellent reply. So Dr. David is saying it has to be a non-punitive culture. It is very easy, when we talk about the tip of the iceberg, everyone remembers the tip, but no one knows that the Titanic never sank because of the tip. It sank because of what was below the tip, the systems. But here it is easy to name, blame, and shame. Dr. David, there's a question for you, directly to you, that are medical errors, do they happen only in complex cases or simple cases? This is Mirta Vidya. She asked.
They happen in all cases, and they appear to occur, reasonably randomly. Now they're probably a bit more frequent in complex cases, and they're probably more likely to harm the patient in complex cases, in part because the complex patients are sicker. And simpler cases are more important, but we find them, just sprinkled all over. They're everywhere.
Now, if we remember the presentation that Dr. David had put, there were lovely figures put, and even in medication errors, this question is linked to it. That's why I brought it up. Even in medication errors, I think we wrote that about 49% of the errors happen in the ordering stage. That is during the physician stage. So now, sir, you being a clinician and you being a champion of technology and errors, this question is asking, this is Dharmik who's asking you, how do you change the old, and I'm emphasizing old here, how do you change the old mindset of a clinician to adhere to new technology in developing countries like ours?
Yeah, I mean, it takes some time, but people will adapt. I'm sure that all the physicians are carrying around, their personal device. They've adapted to using that. This is really can be set up so that it's quite simple, and it's actually easier than many of the approaches that we are using today. Handwriting in particular is really slow. It's hard to recognize. It's just much better to do things electronically. Are there still a lot of handwritten orders in India? I would assume that there are.
Mostly.
Yeah.
It's interesting because we have someone who's named themselves the anonymous attendee, and they are asking you, is there a specific and different definition between reported and unreported medication safety? That is the first part of the question. And the second part is, why is there a difference in the nurse's assessment between medication safety reports for doctors and medication safety reports using incident reports? I'm not sure what that was, but yeah.
Yeah. Well, there's a big difference between, what gets reported and what the actual harm rate is. So for example, we did a study in which we looked at that, and we found that only 1 in 20 adverse drug events was actually reported as a safety problem. So that means that it's like the Titanic. 19 out of 20 are hidden, and you don't find those unless you really look for them. So I think that's a big part of why we've underestimated the severity of this problem for so long. It's really a big problem.
Great answer. So there's a question, I think, from Nishant Jaiswal, who should be, I think, Nanavati Hospital. I think I know him. He's asking you, sir, is there any medication error capturing tool like we have the IHI capturing trigger tool?
Well, for medication errors, the best approach is really to spontaneously report them. I mean, for detecting adverse events, the IHI trigger tool is a very good tool to use to rapidly screen a patient's chart for adverse events. That's probably as good a tool as there is for finding adverse events quickly by going through a chart.
Great. Yulia says, thank you for the interesting presentation, Dr. David, and she wants to understand, do you, in your experience, feel artificial intelligence as a technology can support medication safety?
Yeah, we've just written a paper about this in the last few days. Ironically, I think it will play a big role. It will probably play a role first in pharmacovigilance. So in other words, in terms of finding problems with drugs that patients take that we maybe didn't know about until we looked at afterwards. I think it can also play a huge role in terms of selecting the best drug for an individual patient, because artificial intelligence will let us take into account all the different factors about someone, and that'll allow us to make much better choices around that. It'll also allow us probably to pick medications that will be safer for specific patients. So this is one of the areas that I'm most excited about right now, and we're actively working on that.
Great. Akio writes, thank you for your great presentation. I could not agree more on the benefits of HIT. but are there any risks that healthcare professionals, uncover when using computer screens and barcodes rather than talking to the patient's face and voice?
Well, they certainly have to keep talking to the patients. Ideally, the way that when this is set up well, they'll actually spend less time with the computer system and more time with interacting with patients directly. I agree that that's absolutely pivotal. When this is done well, it can be pretty seamless and very, very quick.
Great inputs. And so what Dr. David is saying is that you can never substitute the actual talking that you need to do to the patients, no matter what technology you have. Then there's
Exactly.
a question. There's a question, with respect to something in India. Change management is a significant issue in India. Can you provide your expert opinions?
Well, I would say change management is a big issue everywhere. If India wants to move forward as it does, it absolutely has to master some of the techniques of change management and learn from change management. Now, I would say that a big advantage that India has is you essentially have all the levels of development in one country. So the best hospitals in India are some of the best hospitals in the world, and then as you go to the countryside and to the smaller places, things are very different. So you have the advantage that you can look and see how things should be done, and then really put in place changes to make the system work better everywhere. So I would say that there's some advantages to having various levels of development.
Great input. When you talk about change, the only thing I remember, the only thing which comes to my mind is everybody says change is good, you go first. So they're always looking at the other person. We have something from Tangam Gomez. I know her too, ma'am. Good evening, wherever you are listening to us. It's an honor to listen to you, Dr. David. After CPOE, the administration figure did not change. Any specific insight?
Really good question. The error rate actually did go down some with the administration error rate, just not as much as, for example, the rate at the ordering stage. And I think to improve safety at the administration stage, the big interventions really is barcoding, and that is what will result in improvement at that stage. Smart pumps too for intravenous drugs.
Okay, now this is a question, which again is about culture. Everybody is talking about a just culture to improve medical errors. I am working in Saudi Arabia as the QM director in a group of hospitals, but I never see in any hospital this environment of just culture is there or achieved. So,
well, it does take a very long time. I mean, I feel like we're finally pretty close to that, but we've been working on it for maybe 15 or 20 years. It's not the sort of thing that you can just say that you want to do it this year and then be there by the next year. It takes a long time. Everyone has to buy in. In particular, the leadership has to kind of understand the concepts thoroughly. And then when something bad happens, they have to not punish the people who made the mistakes. I mean, even at our institution, we had one really bad incident 5 or 6 years ago, and the first thing that our leaders wanted to do was to fire the individuals who were involved. Like you can't. I came to them and said, you can't do that. That's not the right approach. We're trying to build a just culture. If people see that you did that, they'll be pointing fingers for the next 10 years. And so you know, it takes a lot of time and a lot of effort, and still, you know, I think it's a destination. You know, it's very hard to get all the way there.
Then I think there's a comment from Dr. Girish, which I will put my view before I give it to Dr. David, because it's based, you know, something in India. So Dr. K. Girish writes, in India, even if nurses commit mistakes in administering medications, ultimately doctors are held responsible. Before you answer that, Dr. Bates, I would like to say here, the problem is we don't showcase all of this, you know, and doctors are never held responsible. So if this is happening in some place, it is sad. Otherwise, you know, so what is your view on this, Dr. Bates? They say if nurses commit a mistake, the doctors are held responsible.
No, I think it shouldn't be any individual really that's responsible. It should be the whole team in the institution that is responsible when
that system. Yes.
Yeah.
So because, you know, we talk so much about quality, we talk so much about everything. If we remember the Swiss cheese appearance, Dr. David spoke about clinical pharmacists. Clinical pharmacist is not a god who will prevent something. He's a part of the system. He's going to work there. And when multiple things fall through at different levels, that is when harm reaches the patient. So, yeah, so then there is another question. I think the last, because we had a time cut by 6 o'clock. Dear sir, can you explain the relationship between diagnostic error and medical error?
So diagnostic error is a specific category of error. We're doing a lot of work on that right now, actually. It's not clear what proportion of all harm is caused by diagnostic errors. And they've been some of the most difficult to try and prevent. It's also hard to define, you know, exactly what is a diagnostic error. Is it just, for example, if you were a little delayed in making a diagnosis? How delayed were you? You know, is that enough to count it as a diagnostic error? So there's a great deal of work going on in that space right now in this country. And I'd encourage you to take a look at some of the work of Dr. Hardeep Singh, who's in Texas, who's done some of the leading work in that area.
I think the last question, you know, there are a lot of other questions, but we have to adhere to the time given. The last question again from Ms. Gomez is, it is interesting to hear about just culture. Dr. David, any insights on having a decision tree for different levels of behavior?
A great question. You know, one thing that we do is we have all our employees take a survey every year, and it's mostly aimed at figuring out where are we in terms of getting to just culture, and that survey does give you an index as to where you are, and you can compare things, and we find that for example, between units, there's often very big difference in what the safety culture is like. You know, if the unit has a particular type of leader, you know, sometimes the level of safety culture is very low, whereas with other leaders, you know, it's much different. And that was extremely helpful to us in terms of going from unit to unit and figuring out, you know, what do we need to do to make things better.
Wow, so we, I think, covered 20 questions in 15 minutes, and I think a lot of people have soaked up everything that you have said, sir. So thank you very much on behalf of the participants, and I'll hand over to you, Dr. Laddu.
Oh, thanks so much for having me.
Thank you so much for that brilliant session, Dr. Bates, and for sharing your time, and Dr. Clive for sharing your time and for moderating the session so well. As you know, we want to really thank you for the time, and I would request Dr. Ravindran Jagasoti to present a small memento to our speaker virtually. Over to you, Dr. Ravindran.
Thank you, Dr. Bates. It's a great pleasure to present this certificate to you virtually. You have been a good friend of ISQua and now CAHO, and of course, you have done sterling work for ISQua. And I think it is astounding the number of questions that have come in for your talk. I can count 31. That's fantastic. Thank you, Dr. David Bates.
Thanks so much for having me.
Thank you very much, dear participants, for your patience, for the time that you could spare for this very important ISQua CAHO Joint International Webinar Series.